Tonight we're going to talk about common disorders of the hand, and it's funny that I can think about the top 3 disorders I see, but really there are quite a few things that kind of tie for 1 through 5. So we'll talk about 3 of the more common ones I see, but certainly one of the other things I see quite a bit are cat bites and cat injuries. This handsome beast here is very cute, of course. Nobody can say anything bad about that, but they can sometimes get after you if they get cornered, and so just be careful of those cats out there. That's my public service announcement for this evening. Our common hand problems this evening we're going to talk about are trigger finger, arthritis of the thumb, and carpal tunnel syndrome. So I'm sure a lot of people out there have had issues with this in the past, or maybe know somebody who's had issues with this. And the plan tonight is to go through these, and of course at the end we'll be taking some questions from the audience as well. So trigger finger, this is otherwise known as tenosynovitis, and this graphic here that Erica helped me with, put in, it reminds me of exactly what's going on in there. Basically there is a tendon and it's running inside of a tunnel, and it really just can't quite get through that tunnel, and what happens is it rubs on the rooftop of that tunnel, the tendon does, and it gets stuck. And so it's really the inability to smoothly flex or extend the fingers or thumbs, and may actually require you to physically pry your finger back open to be able to get the finger unstuck. It also may sometimes just present with pain. It may not actually be something that shows up as a locked finger, but more just pain to start with. All of the fingers can be affected. The ring finger is the most common, but any finger is fair game, really. This is a medical picture of what that tunnel looks like, and that white part on the finger there is really the tunnel. Below that tunnel is where the tendon is running, and the shot to the left of that finger is the cross section. So if you cut the finger off and look down the long axis of the finger, you would be able to see what that looks like on the left there, and that tendon or those tendons are in that tunnel and they get stuck, and you can imagine there's not a lot of space in there, and it doesn't take much for a finger to get stuck inside of that tunnel. So we really don't know exactly why it occurs. I get that question quite a bit. Why do trigger fingers occur? And we know that there's probably some change that occurs with the tendon and some changes that occur with the tunnel that can cause an increase in size or a decrease in space. An increase in size of the tendon or a decrease in space inside the tunnel that really can account for why people end up getting trigger finger. This increased thickening causes a size mismatch, and there also may be some inflammation in that tunnel, especially if you have rheumatoid arthritis. Other conditions that we see associated with trigger finger are diabetes, rheumatoid arthritis, gout, and carpal tunnel. So basically, if you have these other disease states, it's possible that you are more likely to get trigger finger than if you don't have these. I especially feel that that's true with diabetics. Diabetics oftentimes have more frequently, they have more trigger fingers involved. In other words, more fingers that are involved, and then they also have more severe trigger fingers. So again, diabetics unfortunately get more severe versions of this, and oftentimes those can't be really cured non-surgically. The most common presentation that I see is pain and swelling, as well as locking and catching of the finger. And as I mentioned before, sometimes they can get the fingers back and forth with no problem, or sometimes you have to pry it open. In the case of a thumb, oftentimes you can't actually bend it. And so that can oftentimes happen with a thumb when it's really badly locking and have a bad trigger finger. You can't bend it instead of can't get it straight. On a physical exam finding that we normally see is pain right over the palm of the finger at the base of the finger. So in this area down in here, we oftentimes will have pain. Sometimes there's a painful nodule down in that location. As I mentioned before, there's catching or locking of the finger frequently, and sometimes people present with just a loss of motion. In other words, they may come in, they don't really have a locked finger, but they go to bend their finger down and they can't quite get that finger all the way down into the palm. When we do x-rays, we don't normally see a lot for trigger finger. Oftentimes, really, it's more of a physical exam finding. Our treatment that we treat for trigger fingers non-operatively, we talk about activity modifications. We have a lot of sewing and knitters out there. I know Leah does a lot of knitting out there, and she's watching tonight. And so knitting oftentimes can make it where where the fingers get repetitive stress on them, and sometimes you can see these conditions. Anti-inflammatory medications, massaging, icing, and splinting can also help these trigger fingers. Injections are really the mainstay of our non-operative treatment. Oftentimes we'll get good results. Anywhere from 65 to 70% of the time we can get good long-term results, sometimes permanent. The downside to cortisone, of course, is that you can have some skin color changes. Obviously, anytime you have an injection, there could be an infection. And the cortisone can sometimes eat or take away some of the subcutaneous fat, meaning the thickness of the skin can get thinner in that region. So if you have thin skin, it can sometimes create even thinner skin in that location. So, we do use the cortisone. This is a picture of the cortisone, that frequently used cortisone shot that we use out there. I think part of the problem with cortisone, though, is especially with diabetics, it can also increase your blood sugar. So we're very cautious with diabetics to give too much cortisone here. Additionally, we don't like to give too many cortisone shots lifetime into a location because we don't want to damage any of the tissue. So we really don't like to give too many cortisone shots in a repetitive fashion into the same location. When non-surgical treatment is not working or we decide to go with surgical treatment, it's a very successful treatment generally. Greater than 90% of the people have great results. It can return, but it's not very common. It's a very small 3/4 inch incision at the base of the finger. And we basically go in and we open up that tunnel where the finger, where that tendon is trying to run into that tunnel. So right at the leading edge of that tunnel, we open that up so that the tendon has room to travel. It's a pretty quick surgery, 5 to 10 minutes. Generally, we can do it under a very light sedation or even under a local anesthetic. Like I said, it's a pretty successful procedure. The nice thing about that surgery is people are allowed to use their fingers right away afterwards. We try to limit your lifting to no more than about a pound for about a week. And we like to have that wound covered for about the first week so that it doesn't get wet. So we ask that you put a bag on or a glove on to keep it dry during showering. Most people are back to their normal function and normal activities by about 4 to 6 weeks. Next on the list tonight is thumb arthritis, and we see quite a bit of this in my practice. It's extremely common, more common in females than men. In fact, most people quote that there's about 80% more women get it than men, an 80-20 breakdown. Most women would say that's because they work 80% harder than most men, and I couldn't agree more. Not all thumb arthritis is symptomatic, though. A lot of them are asymptomatic. And because of the physics and the lever arm at the thumb, 1 pound of pinch at the tip of the thumb creates about 10 to 12 pounds of pressure at the base of the thumb. So that base of the thumb really sees quite a bit of pressure and quite a bit of activity when you go to pinch an item. This slide is a little bit busy, but it's really there just to show you the complexity of the thumb. The hand is obviously an amazing apparatus, and just this slide alone shows roughly the 16 described ligaments that surround the thumb, and so you can imagine how everything has to be elegantly balanced for that to work properly. Why do people get thumb arthritis? We're not exactly sure. We think that it's probably multifactorial. There's probably a little bit of ligamentous laxity, meaning one of those 16 ligaments may be a little bit more lax, and the thumb slides a little bit more. And that may be why the women have a little bit more susceptibility to it, because their ligaments of the thumb are a little bit more relaxed. And you can imagine if the ligaments are a little bit more relaxed, there's a little bit more motion, that just means those surfaces are gliding over each other in a much more, in a longer fashion, meaning the distance that it travels is much longer. The thumb also has a lot of degrees of freedom, right? It's not just a up and down motion, it can circumferentially move. And so again, there's a lot of different pressure points that joint sees. Interestingly though, we can see really bad x-rays of arthritis, but it doesn't necessarily correlate to your symptoms. Oftentimes I'll see patients that come into the office and their x-rays look really bad. They have really bad arthritis on their thumb x-ray, but they're not even there for their thumb problem in the first place. They're there for maybe a trigger finger. So it is interesting that you can have really poor looking x-rays and really not be affected, and the same is true vice versa. You can have pretty normal looking x-rays, but actually have very symptomatic early arthritis in the thumb. So we know that the pattern of degeneration really occurs in a predictable fashion. Initially, there's probably a little bit of laxity at the joint. The x-rays start to show a little bit of joint widening. And then ultimately, as the cartilage starts to wear, the joint space on the x-ray begins to narrow. Ultimately, some bony spurs can develop, and you'll ultimately get a little bit of a bump at the top of the thumb at the back there, because the thumb starts to slide a little bit out of the joint, and that can create a little bit of a cosmetic deformity. And people think that there's a new growth, but really it's just the base of their thumb starting to slide out a little bit more. This x-ray is a picture that I commonly see in the office, and you can see that thumb is really in a zigzag type deformity. And the reason why that occurs is in really significant thumb arthritis, the base of the thumb can become more immobile, meaning less motion occurs at the base of the thumb as the arthritis can worsen. Because of that, it becomes difficult to get your hand around an object. So for instance, if you're trying to grab a bottle of water or anything bigger, it can sometimes become very difficult to get your hand around that. And so the body, being smart, of course, can try to compensate for that by trying to take the next joint and hyperextending to be able to get your grip out so that you're not as dysfunctional with trying to grab items. Unfortunately, that can lead to this zigzag deformity and ultimately create a bigger problem, because now you have two joints that have an issue. Most commonly, I see people that present complaining of inability to open jars, turning keys, doorknobs are difficult. They oftentimes will have pain with prolonged writing, pain lifting a coffee cup, and it also can coexist and be confused with other conditions. Some people think it might be tendinitis. Some people feel like it might be an early trigger finger or even wrist arthritis. So it can be confused with other conditions. This is a device here that sometimes we use to measure pinch, and I really put this picture in there because I wanted to show you that zigzag deformity. You can see how sunk in that joint is, and that's because that joint has become hypermobile because it's trying to be able to compensate for the lack of ability to get the thumb wide around objects. One more thing I want to point out is oftentimes people will present with pain at the base of the thumb down in the base down here on the palmar side, and that's a really common spot that people have pain. So on physical exam, this is again another picture of how that Z deformity might present. The thumb might even appear a little bit dislocated. There's a tendency for patients to feel like there might be a dislocation feeling of the thumb. And oftentimes, like I said, people present with pain along the base of the thumb, like I showed you before. This is a pretty common x-ray I see. This is not a really bad x-ray of arthritis, but certainly a pretty common early beginning arthritis at the base of the thumb right there. Our non-operative treatment, again, involves activity modification, so larger grips on golf clubs. I know I'm getting to the situation now where my hands may not be having a nice tight grip on that club, and sometimes we have to increase those grips. Anti-inflammatories can help. If there's no contraindications for you taking that would be like ibuprofen, Motrin, or Aleve. Injections work very well for this, and then splints. A word about the injections again, very successful for the first couple of injections. Long term, unfortunately, those injections, people become a little bit more immune to them, and they don't really work long term forever. Additionally, we don't like to keep putting repetitive cortisone shots again into one area, so after about 3 or 4 injections, I really try to talk people into a different mode of treatment. And then splints, we talked about briefly. There's a couple different kinds you can find. These are these are custom fabricated splints by a therapist. One's a little bit more on the forearm, and one is more based in the hand. You can certainly pick these types of splints up over the counter as well, and those can sometimes be helpful. Unfortunately, if you're an active person or have your hands in water quite a bit, taking the splints off can be quite a hassle. Most people will benefit from splinting, but sometimes if you're a thinner patient, especially if you have that bump on the back of the hand, the splints can sometimes push on that bump of the hand and actually cause some increasing pain. And so sometimes splints, which may be helpful at the beginning, may not be as helpful down the road because it starts to cause more pain just from the sheer fact that's pushing on the thumb itself. Long-term results of corticosteroid injections have been discouraging, but certainly short-term results have been very good. And I can tell you anecdotally from my 13 years of experience, I really think patients do benefit in the short run from injections. So the decision for surgery is basically made by the patient. It doesn't matter how long you wait on this. You can wait as long as you want, and there's always something I can do surgically down the road to help the arthritis. So there's really no rush. There's multiple different options for surgery, but they all involve the same variation, or excuse me, a different variation on the same theme. And basically what we're doing is we're getting rid of the bone that was grinding on the other bone and creating a space there so there's no longer anything rubbing on that bone. And oftentimes we'll put something in that space to help create a cushion so that the bone or the metacarpal doesn't collapse back down into that space. Normally with surgery, we have people in a splint, and oftentimes they'll wear that for about 6 weeks. They're allowed to take it on and off for showering after the first couple weeks, and we start some therapy. The pain does get reliably better with this procedure. It's a pretty successful surgery. The strength may or may not get better. Sometimes people's strength is not dependent solely on that thumb arthritis. They may have other reasons why they have lost strength, and therefore obviously may not get better with this surgery. Therapy is oftentimes needed after the surgery to get your strength back and your range of motion. There are multiple techniques, like I mentioned before. The pictures shown here just show a couple of different options that are commonly used in the United States right now about how to address this problem. On the top screen, there's a couple of little anchors that you can see, metal anchors. On the bottom, these are some intraoperative x-rays of some wires where we're trying to localize exactly where we're going to put some suture. And that can be helpful to help achieve our goal of getting people better again for this condition. Lastly tonight, I want to talk about carpal tunnel syndrome. It's extremely common. It's probably the single most commonly performed surgery in the world. My motto is, if you live long enough, you'll probably get carpal tunnel. That's how common it really is. Really, carpal tunnel involves the nerve being compressed at the hand and wrist, creating a problem down into the fingers. It's more common in females than males, but really, in my experience, it's really 50-50. It is clearly the most common upper extremity nerve compression syndrome that I see. Peak age is at 45 to 60, but I see people anywhere from the age of 17 years old all the way up to 100 years old get it. So it really is a fair game for everybody. The anatomy, again, this is a cross-sectional picture. So if you look at this drawing, again, if you take off the hand at the wrist and you're looking down the cross-section of the hand and wrist, you can see the bones on the bottom of the screen there, and on the top is a ligament over the top. In the middle there, those are all tendons, and then there's one nerve. So there's 9 tendons and a nerve that run through that area, and that ligament on the top is what's pushing down, creating the compression. And that is generally what we go in and try to release when people are having surgery for this condition. Again, as I mentioned, 9 tendons and 1 nerve occupy that space. Why do people get carpal tunnel? I get that question a lot. One of the forefathers of hand surgery, George Phelan, said the median nerve is easily compressed by any condition that increases the volume of structures within the carpal tunnel, which is a fancy way of saying that we really don't know, but anything that causes increased pressure in that region can give you carpal tunnel. Some of the common things, you could have a congenitally small tunnel, so you may have just small bony anatomy that can create the problem. Systemic conditions can create a problem like diabetes or thyroid issues, or repetitive use. So somebody who might be bicycle riding or motorcycle riding can get vibratory forces on their hand that can definitely create issues. This is a very short list of 90 examples of some of the things that can cause carpal tunnel out there in the world. Most of the time we see from a clinical presentation pain. Oftentimes we'll see burning sensation. Fingers can feel like sandpaper when it's really advanced or really far along. I have a lot of people that come in and say that their tips of their fingers feel like sandpaper. Maybe they feel like there's water on them even though there's no water. Oftentimes people will feel like they have cold fingers even though if you feel their fingers, they're room temperature or no different than the other fingers on the other hand. It can definitely create focal pain and again, can create a loss of dexterity. So fine motor skills, I can't pick up change. Again, trying to thread a needle for sewing becomes very difficult. Earring backs for women, bra straps for women can definitely become very difficult as well. And so it's a very common thing that we see with really late presentation of carpal tunnel is that dexterity. People also complain of weakness in their hand, and oftentimes that can be a problem for patients. So really the questions to ask yourself is, does it wake you up at night? Does the hand bother you when you're grooming? Does it bother you when you're driving? Do you have to frequently shake your hands out at night or during the daytime to try to get that feeling back? And those are some of the common ways you can maybe self-diagnose whether or not you might have carpal tunnel syndrome. Physical exam, it depends on how far along this is. If people come in with just some early carpal tunnel, it might just be occasional numbness and tingling in the fingers. Late findings, you can see loss of muscle at the base of the thumb, because what happens is if the nerve is being compressed, the nerve fibers that go to the muscle are dying and the muscle disappears. And so unfortunately, once that muscle starts to disappear, oftentimes the muscle does not come back even if you try to solve the carpal tunnel problem. Oftentimes you can have concomitant issues like trigger finger or thumb arthritis, inability to discriminate between objects. So the fine motor skills, of course, I talked about, but just even being able to know whether or not you have an object in your hand, it's easy to present with a loss of ability to even know that. Doc, I was holding something, a paper plate, and it just slipped out of my hand, but it's happening a lot. I get that quite frequently. Or I'm holding a glass and it just slides out of my hand, because we don't know how much pressure we're holding, and therefore things can fall out of the hand, and that can be from significant carpal tunnel syndrome. So from a physical exam standpoint, we do obviously check your strength, and we look at that muscle. Is it starting to disappear or not? Testing, we oftentimes will bend your wrist and see if we can recreate the numbness and tingling in the fingers. One of the reasons why it happens so commonly at night that this bothers people is because we oftentimes will sleep with our hands bent, and when that happens, we're compressing that nerve even more. And that's why a lot of times at night people wake up, they've got symptoms, they have to shake their hands out. And we oftentimes will see people show up with complaining of nighttime symptoms more frequently. X-rays generally don't show too much. We do them because sometimes there can be some other issues causing space-occupying lesions or problems within the carpal tunnel, but oftentimes X-rays are pretty normal. Ultrasound can show some decreased space in the carpal tunnel. There's been some good articles that look at that, and that very well can help make the diagnosis. MRI and CT scans have a limited role. Quite frankly, this diagnosis is really made by physical exam and by history. Oftentimes we'll get nerve studies where I send you off to a neurologist, and they can help do a test on you that can look to see if you specifically have a compressed nerve at the hand or wrist. And oftentimes we'll do this if we're not really sure about the diagnosis. People many times can have compression of the nerves at their neck or at their elbow, and this can cause problems and can mimic problems down in the hand and can sometimes complicate the picture a little bit. Or they can also have carpal tunnel in addition to these other diagnoses or these other conditions. And so it's good to get the nerve test because it can help us figure out whether or not somebody has these other conditions as well. Oftentimes I'll get nerve studies as well in younger patients because carpal tunnel can come back. And it's nice to have a baseline set of numbers. If you have carpal tunnel syndrome, we have a nerve test. We ultimately do a surgical procedure, and maybe 10 or 15 years it comes back. We have those baseline set of numbers to kind of compare new numbers to see if you really have a recurrence of your carpal tunnel or not. It is important to note, though, that the nerve test can be negative in some patients, about 10 to 15% of the time. That does not mean you don't have carpal tunnel. It's important to note that it is possible to have carpal tunnel with a normal nerve test. Abnormal values for these studies can start to, if the numbers get above 4.5 milliseconds, that's when we start to get a little bit worried. I had a patient come in today to the office. Her number was at 9.5. So the higher the number, the worse it is. It's a little bit like golf in that respect, and you do not want to be the high score on this one for sure. Non-operative treatment, carpal tunnel. Splinting is very common. We'll use that, especially at night times, to help prevent the bending of that wrist like we talked about. Oral anti-inflammatories, again, if there's no contraindications, we can do that. That can help reduce some of the inflammation. And certainly if you're sitting at workstations for long periods of time, keyboards, mice, etc. We like to make sure you get ergonomic workstations that can definitely help relieve some of the symptoms. Injections can definitely be helpful. My experience has been it's not really a permanent fix, and the studies would show that most people that have injections, by about 9 months to a year, those symptoms have returned after an injection. And the real problem is the longer that pressure is going on inside of your carpal tunnel, the more likely it is it becomes permanent, and the more likely it is that I can't make you better. So really, this is one of those conditions that is time dependent, and I really encourage people to seek out medical advice or medical help if they feel like that they might be getting some carpal tunnel. Prolonged severe symptoms with weakness probably don't benefit from non-operative treatment, although certainly you can try it. But if you have a muscle that's kind of already starting to disappear, those late findings, it really becomes a situation where I try to urge people to consider surgical treatment at that point. The operative treatment, I want to thank Rich for giving me this picture as well. The operative treatment here, it's a very small incision. It's a 1-inch incision in the palm. Pretty easy, straightforward outpatient procedure. That ligament that we talked about at the beginning, we basically go in and we just release that ligament so there's no longer any pressure on it. This is the mini open procedure, most commonly done across the United States right now. In the past, these incisions were a lot bigger, but these incisions are quite small now. And post-operatively, the hand is in a soft dressing, pretty small dressing. You're allowed to use the fingers right away. We encourage you to do so that they don't get stiff. And again, we just ask that you try to keep the hand dry for the first 12 to 14 days. But really, you can do things like writing and typing and eating and drinking, just no heavy lifting and until the stitches come out. After the stitches come out in a couple weeks, we let you start to get back to your normal activities as you can tolerate. There's always some questions about, do I do this laparoscopically or endoscopically versus open? I actually do both procedures. I'm very comfortable doing them both ways. And we oftentimes will choose one way or another based upon specific issues with a certain patient. And it's a little bit outside the scope of this discussion tonight, delineating when I use open versus endoscopic. But the endoscopic procedure works quite well. There's probably a little faster return to work with the endoscopic versus open, but quite honestly, at about 6 to 8 weeks, there really is no major difference between the two procedures if done correctly both ways. The complication rates are about equal, and there are times when we plan to do an endoscopic approach, which is a small incision at the wrist, and we sometimes have to convert it intraoperatively to a small open procedure because there might be a strange nerve branch in our way and we can't safely get it done through a scope. So I always tell all of my patients we reserve the right to convert the endoscopic to an open procedure if we need to. This is kind of what it looks like if we're going to do an endoscopic procedure. You can see the incision line or the purple marker at the wrist crease there transversely just next to my initials. We now move that incision a little bit higher up. I used to put it in the crease down there, but I go to the second crease a little bit further up on the forearm. I feel like the wound heals up a little bit better as it's a little bit higher up. And so you can hardly see those wounds generally when they heal. This is an intraoperative video of me doing an endoscopic carpal tunnel. And on the left, this is the tourniquet in the background. This was really just to show how quickly this procedure is done. Obviously, the video has been sped up. I don't move this quickly in the operating room, but you can see that we're working to gain access into the tunnel. On the right side is what I see on the screen once I introduce the scope into the wrist. And so the plastic lining on each side keeps us safe from nothing going into there. And you'll see when I put this scope in right here, you'll see the image move on the right and the scope being advanced all the way down to the end of the palm. That stuff you're looking at above is the ligament that we talked about. And you'll see that I deploy a blade here to help release the ligament. And then I go back and check it to make sure it's been released all the way. And you can see the muscle there right above it. And we try not to cut too much of that. And then the ligament is completely released while we're using the scope. And that procedure, from when you saw me start on the left side to on the right side, and you can't really see the tourniquet time there, but it was about 5 minutes. So it's a pretty quick procedure. Of course, they'll want you ahead of time at the surgery center, and they'll keep you after at the surgery center. But the point is the surgery is a pretty quick procedure, whether you do an endoscopic procedure or an open procedure. So, I think The real reason to do carpal tunnel is to prevent it from getting worse. I always try to tell people, I cannot guarantee whether or not I can make you better for carpal tunnel. We go in, we try to take the pressure off of the nerve. Hopefully the nerve gets better and hopefully your symptoms get better. But if you do nothing, more often than not, you will get worse. And so the real reason to go in is to prevent further progression. Secondarily, of course, is to relieve all the symptoms. Numbness, tingling, and pain, as far as the improvement, is variable. And so if you have long-standing carpal tunnel, oftentimes I can't get rid of all of those symptoms. But really, if you have a lot of pain, oftentimes we can get rid of the pain. So in summary, carpal tunnel, trigger fingers, thumb arthritis, they all can coexist. They really are in the top one, maybe one, two, and three of the conditions I see. In addition to that, oftentimes we'll see some people with something called Dupuytren's disease, where they have little nodules in their hand. That can be confused with trigger finger, and so they can also coexist with trigger finger. So it's really important to be evaluated by a hand specialist if you're concerned that you have any of those issues. A trial of non-operative measures usually is indicated in most patients, with the caveat of what I told you about with regards to the carpal tunnel and long-standing carpal tunnel. Splints and anti-inflammatories and cortisone shots can be really helpful and really are the mainstays of non-operative treatment for all three of those conditions. Nerve studies can be negative with early carpal tunnel, but they really are sometimes important to obtain, especially if we're concerned about other issues. And operative treatment, certainly for cases that are refractory to non-surgical methods, is usually pretty successful for all three of these conditions. I want to thank everybody for tuning in tonight. We're going to open this up to questions, and I'll try to address as many questions as we can tonight. Obviously, if you have a very specific question for yourself, we may end up having to defer that, and certainly either myself or one of my partners can see you in the office, and we're always happy to have that discussion with you live or with our telehealth visits that we offer as well. So, thumb arthritis oftentimes really responds quite well to injections. The real question is what happens when those injections are no longer working. And I'm a big proponent of anti-inflammatory creams because I believe that they're relatively safe. I think that they can be very helpful. But outside of anti-inflammatory medication, either orally or via creams, cortisone injections, splinting, heat can sometimes be helpful. Those really are the only treatments non-surgically, or I should say the more common treatments non-surgically that we use for that condition. So as I mentioned earlier, Dupuytren's and trigger finger absolutely can coexist. Dupuytren's disease is a disease that was described by a French guy in the 1700s. He was the third guy to describe it, so he stole all the glory from the other two guys before him. But basically what it is it's a genetic condition where there's extra collagen that's deposited into the hand. We use collagen all the time for developing tendons, etc. But it gets deposited in the hand. And no, unfortunately, we cannot take collagen from the hand and put it in the face. It doesn't work that way. I get that question a lot. But basically, this extra collagen gets deposited in the hand and can sit on top of that tendon sheath. And that alone can create extra pressure, which can start to create a trigger finger. So it's interesting that I do see a fair amount of people with a small nodule, and that nodule really is early Dupuytren's disease, and that can cause some triggering. That doesn't necessarily mean you have to have Dupuytren's if you have a trigger finger, but I oftentimes will see those two coexist. Trauma can cause a lot of problems with a hand. I've seen patients who have never had a problem with either trigger finger or carpal tunnel or arthritis, and they fall and hit their hand, and it can absolutely flip the light switch on and all of a sudden start causing problems. I've seen carpal tunnel start up from falls or from trauma. I've seen thumb arthritis show up from trauma, and certainly trigger fingers can show up from trauma as well. So there's no question that any of those can happen. I see a lot of swelling in the hand from both carpal tunnel and arthritis. Occasionally, trigger finger can cause some swelling on the back of the hand, but really I see a lot of swelling really in the top of the hand, more towards the thumb side with thumb arthritis. I see that quite a bit, and that's pretty common. Oftentimes people will present with swelling on the back of the hand or wrist, and it may be related to the thumb. Now, having said that, we'll get an x-ray because there's a lot of people running around with arthritis inside of the wrist, which can cause the swelling on the back of the wrist, and we don't want to confuse those two issues. So for de Quervain's, for people out there who don't know what de Quervain's is, a Swiss gentleman got his name on that disease process, and basically it's a tendonitis at the base of the thumb, further back where the arthritis is at, but really kind of more in the wrist. And again, not unlike trigger finger, there's a tunnel where the tendon is running through that, and that can create an inflammation in that location. There is no deleterious effects of treating de Quervain's non-surgically forever, really. It's all about what you want to put up with. So if you want to treat it with a brace or anti-inflammatories or even an occasional cortisone injection, there's no problem with doing that. Aside from the fact that, again, I wouldn't want to inject that location with too many cortisone injections, but there really is no downside to never having surgery for that condition, for any tendonitis, really, because we can always do a surgical procedure down the road that will more often than not help that. The splints that we use for thumb arthritis, I showed a couple of pictures of those splints. I think that you can use the short one or the long one. Over-the-counter splints are more than fine. I think the advantage of the custom-made splint made by a hand therapist are just that. They are custom-made and therefore made specifically for your anatomy. The downside to custom-made splints is they are generally made out of some sort of thermoplastic type material, and sometimes can be a little bit painful because they're not really cushioned very well sometimes. So if you have a really thin hand, they oftentimes can cause some pain by pushing on that region. So just a simple over-the-counter splint would work just fine. At your local pharmacy, you can find those. So carpal tunnel can definitely cause electricity type symptoms in the fingers. Oftentimes we'll tap on the wrist to see if that electricity travels down the wrist, and those are really annoying for people. They oftentimes will come at nighttime, and so that is a really common side effect or symptom of carpal tunnel syndrome. Specifically, if it happens in the thumb or the index or the middle fingers, those fingers, if they're affected, are more commonly associated with carpal tunnel at the wrist. If it's more of the pinky finger or the ring finger, oftentimes that can be associated with a nerve compression at the elbow. And again, your hand provider can certainly help you make that diagnosis. Wrist pain in and of itself can really be a number of different conditions. You could certainly have wrist pain being caused by arthritis. It could be being caused by carpal tunnel. There's really no way to know that unless you're being evaluated by a professional, a hand provider. Oftentimes x-rays can really help delineate whether or not it's arthritis or not. There's a lot of times that there's been some ligament damage in the past that people don't even know about, maybe when they were playing sports when they were younger, and now all of a sudden they're getting some wrist pain and they didn't even remember that injury. So really, x-rays and getting evaluated properly are really the keys to making sure that you can make a proper diagnosis. I tell patients that you're going to probably have some real difficulty with that thumb after thumb arthritis surgery for a week or two, because you are in a splint. Now, the fingers are out, and you can use the fingers for light stuff right away, but the thumb and the wrist are immobilized in the splint for about 2 weeks. After that 2 weeks, we take your splint off, and you go into a removable splint like we showed you earlier. And we really ask that you wear that full time unless you're doing therapy or getting it wet. So otherwise that splint stays on for about another month. So for about a total of 6 weeks, you're immobilized in some way or fashion. But after that 6 weeks, you're allowed to come out of that splint most of the time. And we really start working on strength at that time. So I tell people your pain is generally better by about 6 weeks. However, your strength takes a lot longer to come back. And so I tell people it's a good 3 or 4 months until you're really happy that you did the procedure, because that's how long it really takes to get back to those activities that you want to do that really provide the strength. I oftentimes will tell people as well, not everybody gets 100% pain relief with that thumb arthritis procedure. It's very successful, and more often than not, people are really happy with that procedure. But some people may get 75% relief, some people may get 100%, and like everything we do, it's a bell curve. So most people get really good results. Most people are doing really well by 3 or 4 months. But you certainly could be an outlier on one way or another. So cervical spine disorders, so disorders of the neck, can absolutely manifest with problems in the hand. I don't normally see trigger fingers being confused for cervical spine problems, but I absolutely can see carpal tunnel either being confused with or coexisting with problems with the cervical spine. And when we're not really sure about that, oftentimes we'll get that nerve test. The other thing I see a lot of people with is peripheral neuropathy. So especially diabetics who have really significant neuropathy or globalized numbness and tingling in either their hands or their feet. We oftentimes will see patients and we're not sure, is your hand numb because of neuropathy, or is it numb because of a cervical spine issue, or is it numb because of carpal tunnel? So again, being properly evaluated is critical, and oftentimes a nerve test can help us with that.
Thank you very much for participating in the seminar this evening. If you will please take a moment to complete the short poll on your screen, we would greatly appreciate it, and we look forward to hearing your feedback.